Hey everyone, this is Ari Witten and welcome back to the Energy Blueprint podcast. Today I have with me Dr. Roger Murphy, and I'll read you a little bit about his background. He's the founder and past clinic director for a large integrated medical practice located in Birmingham, Alabama. The clinic provided cutting-edge treatments for acute and chronic illnesses. He's specialized in difficult to treat patients for the last 10 years, and he's a graduate of the University of Alabama, Birmingham, and is a board-certified chiropractic physician. He's also the author of 5 books for patients and doctors, including Treating and Beating Fibromyalgia and Chronic Fatigue Syndrome, Heart Disease, What Your Doctor Won't Tell You, Treating and Beating Anxiety and Depression with Orthomolecular Medicine, and Treating and Beating Fibromyalgia and Chronic Fatigue Syndrome, a Patient's Manual. So welcome, Dr. Roger Murphy. Such a pleasure to have you.
Hey, Ari, thanks so much. I'm delighted to be here.
Yeah. So, I think let's start off with the question of what, as far as your background, what led you down this path of getting interested in CFS, chronic fatigue syndrome, and fibromyalgia? Because that's a path that a lot of people probably want to avoid because it's so complex and so hard to help people with those conditions that I think a lot of doctors avoid it. It's also historically been somewhat stigmatized, especially within allopathic conventional medicine, where a lot of doctors have seen these things as hypochondria rather than actual real conditions, which certainly there's enough research now to know that they are very real conditions. But like I said, a lot of physicians really probably wanted to avoid those things, if anything. What led you down that pathway?
Well, for me, Ari, I really believe that fibromyalgia kind of chose me, because saying this tongue-in-cheek, no one would choose to specialize in fibromyalgia. As you said, it's very difficult. Unfortunately, there's a lot of doctors who still don't believe fibromyalgia exists. Those that do don't know really what to do, to treat it. But I had a very typical chiropractic practice years ago, and it was a very large practice. But I started sharing nutritional things to my patients, and I'd always been very interested in nutritional medicine, functional medicine, what I do now. And that just kind of grew to where I started working I went from 100 patients a day down to about 30 a day, because what happens is I started doing nutritional testing and workups with my patients. And I kind of got a reputation here in Birmingham as the doctor to go to if you had been to other doctors and had, no results. And back in the early 1990s, I had a patient that was referred to me with fibromyalgia. Back then, we really didn't know, really what it was, or, we didn't know much about it anyway. And I was able to get Sheila Jones well in about 3 months, just using nutritional therapies that I knew kind of rudimentary back then. And then I just started getting all these referrals from other doctors, colleagues, medical doctors. I did research work for the University of Alabama, Birmingham, here in Birmingham, Alabama. And so I had a lot of medical colleagues, not just chiropractic friends, and I just got a ton of referrals, and I quickly found out that they were not going to be as easy as I thought, and I had 2 choices. I could either just turn them away, or I could try to figure out how to help these folks with this mystery illness called fibromyalgia.
Mm-hmm. Very interesting. And so you developed some protocols over the next several years that went considerably beyond the sort of nutrition interventions that you had done with, I think you said Sheila?
Yeah. So what I found out is what had helped Sheila didn't help the next fibromyalgia patient, or the next one, or the next one. They were helpful, but they weren't to the point that I had this magical cure. And so that set me out on a quest. And pretty soon, within a few years, my chiropractic nutrition practice turned into an integrative medical practice. I was asked to come on the campus of Brookwood Hospital here in Birmingham, Alabama, and we had this rather large 10,000 square foot space there at the hospital. And I had 5 medical doctors who worked underneath me, and we treated an assortment of chronic illnesses. But I was always interested, what was going on with the fibromyalgia patient? Biochemically, what could we do? And so that led to me writing my first book in 2003. The first edition of my fibro book came out. It's now in the 5th edition, 6th edition about to come out. But when that book came out in 2003, I was asked to speak at numerous venues, and it just kind of grew. And then eventually came to the point I sold my medical practice, and now I just see fibromyalgia patients, and my practice is 99% phone consults. I work with patients all over the world at this point.
Mm-hmm. Interesting. So how do you conceptualize the causes of, and I don't know how much you want to separate them out or treat them as one thing, but CFS, or sometimes called myalgic encephalomyelitis, and fibromyalgia. So do you want to kind of dig into one and then the other, or do you want to treat them all as a unified thing?
Well, you need to separate them out because they're different entities. So if you look at fibromyalgia and chronic fatigue syndrome, or ME, they're really, they're the same coin. They're just different sides of the coin. But there's some very distinct differences between the two. If you look kind of like a clothesline, you get a visual of that. And on one end of the clothesline, the clothes down here are fibromyalgia, and at the other end is chronic fatigue syndrome. And they have a lot of similarities. So both of them can have diffuse achy muscle pain, low energy, problems with low moods, anxiety, irritable bowel, a lot of things that they share. But one of the big differences between the two is that those with fibromyalgia may or may not have an issue with their immune system. So they may get, they may have some challenges with chronic sinus infections or some of these other things. But with chronic fatigue syndrome, that is really what separates it out from everything else, is they have something with their immune system that they can't shake. Chronic sore throats, swollen lymph nodes. These things show up over and over again. Whereas the fibromyalgia patient, they may or may not have that. The other thing that separates them out too is everyone with fibromyalgia has a low serotonin state. That's just the way it is. And everyone with fibromyalgia, true fibromyalgia, has trouble with their sleep, either falling asleep or staying asleep, or having a deep sleep to where they feel rested the next day. Those with chronic fatigue syndrome, they may sleep all day. So they may not have an issue with low serotonin. It could be that they're low in other neurotransmitters, in particular norepinephrine. But the thing about it, Ari, is you can be anywhere on the scale. You can have a little more fibro than you do CFS. You could have more CFS than you have fibro. So there are some common things with this. And then the other part of your question, what are the causes? So what we know is really, fibromyalgia is just a name. So it's a name given to a group of symptoms that people have in common: low energy, diffuse, sometimes disabling pain, poor sleep, restless leg syndrome, irritable bowel, mood disorders. But those are just symptoms. And we give it the name fibromyalgia because we don't know what else to call it. But fibro doesn't cause anything itself. And that's really the challenge. The challenge really is, from a functional medicine standpoint, is to find and fix the underlying causes of these symptoms.
Mm-hmm. And just to clarify a couple points that may be of interest to people, when you're talking about it being a constellation of symptoms, in contrast to something that, let's say, you can show up to your doctor, you get a blood test, they say this particular biochemical or hormone is low or high, and therefore that means you have this.
Yeah.
And fibromyalgia and chronic fatigue syndrome, there really isn't that sort of ability to define, to diagnose somebody based on one or even a combination of biomarkers.
Yeah, we see some common denominators in both of them in lab work, but there's no definitive lab work where you do it and you say, oh, you have fibro or you have ME. Mm-hmm. It's just not out there. Now, there's some people that are marketing some blood work right now, and it remains to be seen, because we may find out that it is very useful. But really, both of these illnesses are given as a process of elimination. You go through, you get all the testing, see a myriad of doctors, usually get on the medical merry-go-round, and eventually they give you a diagnosis.
Okay, gotcha. One point I want to come back to on symptoms. I don't believe you mentioned pain, and so is pain that sort of chronic, either diffuse pain throughout the body and hypersensitivity to pain? Is that something that's unique to fibromyalgia as opposed to chronic fatigue syndrome?
Well, they both can have diffuse achy muscle pain, as I mentioned earlier, and I really need to put in there disabling pain, because those with fibro, they want it to be clear to the general public that doesn't understand this illness that it's not the aches and pains that you and I would have going out playing weekend sports. These are very intense pain that they may have deep. It could be, deep in their bone type pain, or it could be muscular soft tissue pain. But yeah, you're so correct. Ari, is that those with chronic fatigue syndrome have pain as well. And their pain is diffuse achy pain, oftentimes described as like a flu-like achy type of pain.
Mm-hmm.
So they both definitely have pain, no doubt about it.
Gotcha. So as we segue into causes, I want to give some overarching sort of context. I've had a lot of people on this podcast talk to a lot of people about chronic fatigue syndrome, and as well as more like stress-related burnout and exhaustion.
Mm-hmm.
And one thing that I've encountered is there are a whole bunch of different kind of pet theories and takes on what are causing this. Oftentimes people sort of zeroing in on one very singular factor. But, some of the people I've had on this podcast have, focused very much on brain issues and sort of psychological, emotional stress, and that being the fundamental cause. Other people have focused on immune dysfunction and chronic infections being the most important cause. Other people are focused really on genes, especially in chronic fatigue syndrome and fibromyalgia. Other people are focused on the gut or, excitotoxicity in the brain from, LPS leaking into the bloodstream, or, and then kind of you have like Alex Vasquez, who's talking about the gut and the mitochondria and the brain kind of as a cycle there. Other people are focused on immune dysregulation, autoimmunity, and some people are focused on toxins. Some people are focused on hormones. What within all of that landscape, what is your take on causes of, let's say, fibromyalgia?
Yeah. So first of all, that was really great how you shared all those different theories, because there's so many of them. There are, and like you said, I like that. What you said, everyone has their pet theory. And they all have, here's the thing, they all have validity, because, again, with fibromyalgia in particular, again, we talk about that a little bit separately from ME, but with fibromyalgia, it's, they're different. Every fibromyalgia patient is different from the next. Now they've got some common denominators, things that they share, but they're all unique in that there's, for this one fibromyalgia patient, there's some key things that have gone wrong. And then the next one, those key things may or may not show up. So case in point would be when we're looking at the underlying causes, for fibromyalgia, what we want to know is, when they say I have all this low energy, and they do, they have no energy. Well, fibromyalgia, the name doesn't cause that. What we want to know is what's causing that low energy. So there's several things that can contribute to that. One, the first one is they all suffer with poor sleep. They all have insomnia, trouble falling asleep or staying asleep, or getting into deep restorative sleep. So that right there causes them to be tired. But I find in my practice, and I've been doing this 20 years, specializing in fibro and chronic fatigue, is that with fibro particularly, I find that about 70% of the patients that I work with have something wrong with their thyroid. And then now you and I know you from your podcast. I'm a big fan. And so this term sometimes doesn't sit well, and we can have our own take on it. But I also find that my patients with fibromyalgia and chronic fatigue syndrome, their adrenal glands are shot. So they have been under stress for so long that now their stress coping mechanisms are not working like they should. And so anytime they get under stress, it is magnified, which creates even more stress.
Cool. Is there anything else you want to mention there? You're a chiropractor also by training. So do you feel there's any aspect of a sort of physical side of this? And I know there are kind of number of avenues you could take in that realm. So one is kind of how peripheral sensitization, like somebody has pain, in their periphery and their limbs and their shoulder or whatever, something like that. And over time that can lead to central sensitization in the brain. So I know a number of kind of physical practitioners who tend to explain fibro more from that lens, kind of because it's kind of more in line with their training. Or even just deconditioning from lack of exercise and movement. Do you feel those play a role for many people?
Possibly, and I really believe that it's it's a biochemical breakdown, or biochemical plural breakdowns, that manifests itself as a physical malady. So the pain is on, they feel it on the outside. But hands-on therapy, I've not seen it to be very, very helpful, partly because they cannot tolerate that tactile sensation. They have a condition called allodynia, where their pain threshold is very, very low, and pain is magnified. So for a lot of fibromyalgia patients, they can't wear a tight shirt or blouse, forget hugging them or handshake or anything like that, or a massage, which, deep tissue massage would put these people in bed for 2 or 3 days in intense pain. So I think the hands-on component, and there are chiropractors and PTs who have had some success with fibromyalgia patients, but I've not seen that be consistent. And so I use this analogy here, Ari, that I think that what happens is, for most illnesses, it's the catalyst is stress. And that sounds kind of simplistic when people hear that, but when your body becomes too stressed out, it has a tendency then to go into a chaotic type of homeostatic the homeostatic mechanisms start to shut down. And so with fibromyalgia, I really believe that we're all born with a stress coping savings account. And in the stress coping savings account, we have certain chemicals that allows us to deal with stress. And all day long, we're exposed to stress of all different, physical and mental stress, chemical stress. And so when we're under this stress, we're making withdrawals from our stress coping savings account. So we've got, serotonin and dopamine and norepinephrine and cortisol, DHEA. So we have these hormones, but we also have vitamins and minerals like magnesium, which is a very important essential mineral that's involved in 300 bodily processes, that anytime you get under stress, you're using up your magnesium. But with the fibro community, they get under some kind of stress, whether that's long-term chronic stressors, dealing with maybe a special needs child or an elderly parent that lives with them, and they're under toxic marriage, toxic work environment, but something comes along that's the straw that breaks the camel's back. And that could be a hysterectomy, that could be an illness, that could be a car accident, that could be the death of a loved one. Something comes along, and when that happens, they totally bankrupt their account, and they're not equipped to be able to handle stress. So stress becomes magnified. And I really believe all these different theories that are out there have some validity. But for me, the only way that fibromyalgia patients can feel good again and stay that way is they've got to get healthy. And that means different things to different people. But a big part of that is finding where they're broken down and starting to fix those underlying causes, plural, of the different symptoms.
Yeah. Yeah, very interesting. I'll mention I did a recent poll with my audience with several thousand people with chronic fatigue, not necessarily chronic fatigue syndrome or fibromyalgia, but this broad category of people who identify as being chronically fatigued. And certainly a large portion of them have chronic fatigue syndrome or fibro. But I gave like a list of 20 or so causes of, just to see what people would self-identify as the factor that that they feel caused their condition initially. And the majority of people just said stress, psychological, emotional stress as being, a period of intense stress. And then certainly sleep problems were up there. Viral infection was also up there and among the top. But I think that combination of an intense period of severe stress combined with sleep problems, and as you mentioned, a huge portion of people with CFS or fibro have sleep apnea or sleep movement disorders or insomnia. I think the combination of those two things just really is a huge trigger. My impression is for the vast majority of people.
So we know that with fibromyalgia, they have this problem with sensitivity syndrome. So pain is magnified. The nervous system is kind of wonky. And we also know that they have a disruption in the body's ability to self-regulate itself. So we have, and you know this very well, but we have the HPA axis, the hypothalamus, the pituitary, the adrenals. And it's our body's own little mechanism to control different systems of the body. In particular, the hypothalamus controls our body temperature, our sleep-wake cycle, how we perceive pain. It's very important, our immune system, our digestion. And normally the body's able to regulate our different systems. I mean, we don't have to think about pumping blood through 60 miles of arteries and veins. We don't have to think about taking 12 breaths per minute. We don't have to think about digesting our food that we ate. The body has a self-regulating mechanism that does this. But when you get under too much stress, that can start to have problems. And then if it's too much stress for too long, or an incredibly acute stress, it can cause the hypothalamus, pituitaries, and adrenals to become so dysfunctional that now it can't regulate digestion. It can't regulate your sleep. It can't regulate your moods. It can't regulate your elimination process. And that's where you start to see these symptoms, which, symptoms are just warning signs that something's not working like it's supposed to be in the body. And yes, it's a theory, but there's a lot of doctors like myself who believe this theory, who've been in the trenches with these patients for a long time. To me, it's what makes sense because there's so many daggum symptoms. There's so many systems that get off track that this model makes sense to me.
Yeah, we could certainly dig into that one very in depth. I do think that HPA axis dysfunction exists in a portion of people. From digging into the research myself, and I've done I don't know if you've seen it, but I've done an extremely comprehensive analysis of the relationship of adrenal and HPA axis dysfunction in CFS and fibro and stress-related exhaustion disorder and burnout syndrome. And it's not found in so many people. It's just undetectable in so many people with CFS and fibro that I just don't think that there is any case to be made that it is the primary cause of these conditions. I do think that certainly you can make a case that it arises secondarily, for example, to sleep problems. Certainly there's a link between sleep apnea, insomnia, and then disruption of the HPA axis. And so you could say as a result of that, then the low cortisol levels and the HPA axis dysfunction then leads to other things. I think the very fact that the vast majority of these people with these conditions have no detectable HPA axis dysfunction kind of rules it out as the primary cause.
So we would have to have a nice polite debate about that, because in the fibro patients, treating them and using all different types of tests, both blood and saliva and urine and different ways of testing this, I find that the overwhelming majority of them have low cortisol or an elevated or very spiked DHEA level and high cortisol levels over what you'd see in normals. So there's definitely something going on there. But you said it so well that sleep, when you see problems with sleep, you're more likely to see these conditions. For me, with fibromyalgia, if you don't have problems with your sleep, you don't have problems with fibromyalgia. So that's the very beginning of fibromyalgia. They may have aches and pains and things of this nature, maybe a little bit fatigue, but once they start struggling with their sleep, that's when you start really seeing fibromyalgia, maybe 6 months, maybe a year, whatever it is. Sleep is the key. You got to get them sleeping. And if you don't, you're going to make very little progress. Now, as I said, with chronic fatigue syndrome, they don't usually, a lot of times don't have any trouble with their sleep. I mean, they could sleep all day and still be tired. But in the fibromyalgia community, if you've got true fibro, you have trouble falling asleep or staying asleep. That's classic fibro.
Just to dig into the adrenal stuff and HPA axis stuff a little bit more, do you use hydrocortisone in your practice?
I don't. When I had my medical practice, when I had the 5 medical doctors who worked for me, at that time we did integrated medicine. So it's a very judicious use of prescription medications. What we did, we used um, all sorts of medications and natural things. And we use Cortef. So we did our work based on William Jeffries' work, Safe Uses of Cortisol. It's an old book, but and we did our work based on that, based on his work. We did our therapy based on his work, and we got really good results. The problem I saw with people on cortisol, was it was hard to come off of that. Now, so what I've gone to when I sold my medical practice years ago, and I couldn't write prescriptions or didn't have anybody there to ask to write prescriptions, I've gone to more natural approaches to address these low adrenal functions.
Mm-hmm. Gotcha. Yeah, I mean, I guess without coming across as too antagonistic, because I generally don't like to be antagonistic, but I just think there's so many layers of the whole adrenal fatigue theory. And as far as I can tell, pretty much every layer of evidence, every place that you could look to see if the theory is valid, it's just not valid. So it's like, to me, it's kind of like if you were looking at diabetes and it were clear that there's no relationship between blood sugar and diabetes, it wouldn't make sense to say blood sugar dysregulation is the best way of diagnosing diabetes. And maybe that's a bad example because we do know that those things are connected, but it's kind of, to me, it's like insisting that this thing is right, even when every layer of evidence is just not correct. Now, what you said is that you're seeing it in the trenches, that when you do cortisol tests, that the majority of people do have it. Mm-hmm. If that were the case in the randomized controlled studies, then I would be very much on board, but it's just not. I mean, the vast majority of studies just find normal cortisol levels. So I don't know, I have a hard time with that, but then it gets a little convoluted because the sleep issues overlap with it. And so if you correct the sleep, then cortisol will normalize. And so you might be inclined to explain that as, well, it's because your cortisol levels have normalized that, and we fixed your adrenals, that you're now fixed. I would explain it more as we fixed your sleep, which affects dozens of different physiological pathways, not necessarily just the adrenals. You know what I mean?
Yeah, no, here's the challenge. So being a doctor working with these patients and seeing the detachment between the studies and what really works, you got to take that into account. It's the same thing with thyroid. So adrenal fatigue, I believe, is real. I see it in my patients. It's not the end all be all. There's so many different things that are going on that if you were just to focus on whether you believe in it or not, adrenal fatigue, you're not going to get very far.
Yeah.
But
certainly we agree on that.
I'm sorry?
I said certainly we agree on that.
Yeah, we'll agree on something. So it's the same thing with thyroid. So with thyroid, you can do testing and it comes back normal. If you're doing basic testing, a lot of times it comes back normal. But what we're measuring with thyroid is how much thyroid hormone is in the bloodstream. We're not measuring what's in the cell. Mm-hmm. So you have this whole thing called euthyroid where you have all the symptoms of low thyroid, but your blood work looks normal. And as soon as you put people on some type of thyroid replacement therapy, they start to perk up. Mm-hmm. And we see that even some of their markers in the blood work start to change from doing that. Now, I really believe it's a whole, as many layers. And that's what, use the term layers. So I talk about in my book, it's like peeling an onion. There's so many different layers of dysfunction that you have to get to, that if you don't address those, you're not going to get very far. If you got 15 tacks in your foot and I pull out 3, are you going to notice much difference?
Yeah, of course
you're not. You're just not. So sleep is number one. I mean, that is the number one thing that has to be fixed.
Yeah.
And then you move on from there.
Yeah. So what kinds of approaches do you take when it comes to fixing sleep? Because a lot of these people have sleep apnea, really severe sleep disorders, or just insomnia. So how do you go about fixing that? Do you have kind of a system for how you approach that?
Yeah. So the Murphree Method, this thing that I've put a name to over the years, because it's a process. I think people that are medical misfits, unfortunately, they go to, one doctor after the next and everyone's got their thing, right? bioidentical hormone replacement therapy. If you go to, certain group of doctors that all think that everything can be fixed with bioidentical hormone replacement therapy.
Yeah.
You go to other doctors who think everybody's got a yeast infection, but what I found is that with fibromyalgia, you start with sleep. That's number one. Then number two, you got to balance the neurotransmitters. We can talk a little bit about that. Then number three, you got to fix the underlying energy zappers. What's going on, thyroid, in my world, the adrenal issues. So there's some things that and then the gut. You got to fix the gut issues. But for sleep, Ari, what I like is 5-hydroxytryptophan. So 5-HTP is an amino acid. You can get it anywhere over the counter. 5-hydroxytryptophan plus B vitamins, magnesium, and vitamin C. That combination makes serotonin. Everybody with true fibromyalgia is low in serotonin because the higher your serotonin level, the higher your pain threshold. The higher your serotonin level, the happier you are, the less anxious you are. It's a happy hormone.
Mm-hmm.
It helps with mental clarity. Also helps regulate your bowel movements.
Real quick, a little digression on that point. Do you think that that's the primary mechanism behind the pain that is seen in fibromyalgia?
I do. I think so. We look at allodynia, where you have this low pain threshold. Something's come along and brought that on. I use this whole bankrupt your stress coping savings account because when you get under stress, you're depleting serotonin, and as well as other hormones as well. But the more stress you get under, the more serotonin you need to have to deal with that. And that's why you see so many patients who have fibromyalgia, they're on antidepressants, number one. But yeah, I do believe that it's allodynia that's driving this. And the goal then is to get that pain threshold up. And you can do that by, getting their serotonin level up. So 5-HTP plus these B vitamins, magnesium, vitamin C, that's where serotonin comes from. But by using 5-HTP, you increase your natural melatonin level, your sleep hormone melatonin, by 200%. So I start my patients off with 5-HTP at bedtime. And then if needed, if they're still having trouble, then I would add melatonin. Mm-hmm. But that's where that's where I start with sleep.
Okay. So was that the whole Murphree protocol for sleep, or wait, when you say the Murphree protocol, does that encompass more than sleep, or is that?
Yeah. So it's the Murphree Method for fibro. It's a real original name, isn't it? But, it's a process where, number one, you got to get deep restorative sleep. And then after that, you balance their neurotransmitters. Then after that, you look for what are the energy drainers. And then you're looking, the next thing that part of that is you got to fix their GI, what's going on in their gut, because they have malabsorption, they have reflux, they have leaky gut, they may have SIBO, they all have IBS, they could have yeast. So you got to find these things and start to fix them. But if you do that process, then you stand, in my opinion, the best chance of having success with them. If you try to do it any other way, if their sleep still struggles and you're putting them on a yeast protocol or bioidentical hormone replacement therapy or turmeric or whatever it is, whatever the therapy du jour this month is, you're going to have very little results.
Gotcha. So I want to dig into the rest of the Murphree. Sorry, it's system or protocol or method?
Method.
Thank you. Mm-hmm. So sleep beyond 5-HTP and melatonin, do you address anything like any aspects of circadian rhythm as far as light therapies or
all of those come in. Yeah. It's very astute of you to ask. So all those play a hugely important role. You got to have good sleep habits. So we definitely focus on that in my book and both of my patients, making sure that you're, using the blue blocker glasses, you're turning the lights down. When you go in your bedroom, it's for intimacy. That's it. Or to relax. You don't want, be watching TV. You certainly don't want to have your computer in there. You don't want to work in there. You don't want to have your iPad in the middle of the night or your Kindle. Anything that's emitting electromagnetic fields or electrical currents are going to sabotage your melatonin levels. So those are super, super important. Other things that play a role in the circadian rhythm is that a lot of times people will be, they'll be tired all day long. And then about 10 p.m., they'll catch their second wind and then they can't go to sleep. So there's ways to make sure that doesn't happen with nutritional therapies you can do. So yeah, there's a whole list of things that have to happen, right? You got to have, your vitamin D plays a very big role in deep restorative sleep, as does DHEA, as does S-adenosine methionine. So there's some nutraceuticals that can be helpful in helping reestablish that circadian rhythm as well.
Excellent. Since there's also a high proportion of people with CFS and fibro who have sleep apnea, do you also do testing for sleep apnea and maybe put people on CPAP machines at all, or is that not?
I don't, but I do have people. I do have a number of people who are on those machines who hate them. By the way, as you probably
Really?
don't like them for whatever reason. They're cumbersome. They, whatever it is.
Yeah.
And what I
I know
find
that for me personally, I could never. I mean, even for me, just sleeping with a sleep mask drives me crazy. So I don't think I could sleep with a whole mask on my nose and mouth.
Yeah, absolutely. But what I find with my patients who have sleep apnea, I can't, be probably hard pressed to even think of, I'm sure there are, but they're all overweight. And as soon as I get them losing weight, which is one of the parts of the equation, getting them healthy, as they start to take off 20 pounds, 30 pounds, they see that sleep apnea is dramatically improved. And now they're able to get into deep restorative sleep without using the CPAP machine. Now, that's not everybody. That's a sweeping statement. I realize that.
Mm-hmm.
But just in my world, working with my patients, I see that the majority are able to get off the CPAP machine just by doing some other things. And one of those things is losing weight if they need to.
Excellent. Well, that actually leads me to another question, a little bit of a digression, but it's a bit of a challenge, I think, for some people with CFS and fibro to lose weight, given the lack of energy and the lack of ability to do exercise in many cases. Mm-hmm. How do you get around that? I mean, obviously nutrition by itself, and somebody who has a really poor diet, just changing nutrition can drive a lot of weight loss, but does exercise figure into this picture at all?
Unfortunately, and coming from your side, you would definitely make it a challenge because I know you're such an expert in that. But for fibro, since they bankrupted their stress coping chemicals, they can't handle stress. Stress is so magnified. So, a lot of these people were type A's. I mean, they were bankers, lawyers. I work with a lot of doctors. High level people. And what they find now, they can hardly handle any kind of stress, any kind of stimulation. And, exercise is fantastic for people like you and I who, I thrive on it. I know you do. But for fibro, they can't handle the stress because exercise is a stress. It's a good stress. It's it has all these health benefits. But for them, for fibro or chronic fatigue syndrome, it's just something in the beginning, at least, that we don't really address until they're doing better. And unfortunately, there's so many doctors out there that don't understand fibromyalgia. I mean, really all they tell people with fibro and CFS to do at this point is learn to live with it. I mean, that's all there is out there. That's what they're telling them.
Yeah.
As soon as I can, though, Ari, as soon as I can get them, once they're feeling better, yes, I get them to start exercising. And it could be something as simple as, and this sounds so silly, probably your audience, but 10 minutes a day just walking in the beginning, just building that habit. And then from there, we start moving, we start ramping that up after a period of time.
Yeah. And no, it doesn't sound silly at all. I mean, that's what people with severe CFS and fibro have to do. And that's where they got to start. Mm-hmm. The subject of exercise in CFS and fibro is pretty interesting because it's really contentious, as I know that among people who treat this. There's a lot of people who are just hardcore in the position that these people should not do any exercise and exercise is terrible for them. And they're under the impression that the science supports that. And then there's other, I've actually dug into the science quite a bit, and there's actually research kind of going both ways. And there is research supporting that exercise is beneficial. There's also people who definitely have regressions from it. And I think the dose obviously plays a big role into whether the dose of exercise that's being prescribed is right for that particular individual. But then there's also some really interesting research around, because there's been this kind of polarization among experts in the field around exercise, you have this idea out there that these people should never do exercise. So as long as you have CFS or fibro, you should never do any exercise. So there's now a phenomenon where patients are getting that idea in their head, and I'm not gonna quite represent this totally accurately, but I believe this study, if I remember correctly, was looking at specifically patients with that belief system and how it predicted their response to exercise. And basically they found that if you had that belief that exercise was going to make you worse, then you were much more likely to be made worse by the exercise. So it's kind of interesting how the psychological stuff now integrates with the actual exercise component.
Well, isn't that true with everything, right? So we look at quantum mechanics and, look at energy medicine. And when you put attention to something, it changes it, right? So we know that. But I'm really, I think, and maybe I just kind of heard this in your tone. I'm with you. I really believe that exercise is super important for these folks, but it's got to be done the right way. And the studies that I fall back on are very positive about it. But the challenge is to get them strong enough so they can do that. And then like anything, as they start to do that and they build up that stamina, it just gets better and better and easier. And they start seeing the benefits. I really believe in the general population, I think that exercise is the panacea. It's the missing link to keep people healthy for years to come. I really believe that. I think diet is super important, but I really believe exercise, physical activity, and having that time to turn your mind off too, to kind of get in, to the zone and turn everything off. I think that is crucial for optimal health.
Yeah, I'm with you 100%. So getting back to the Murphree Method, neurotransmitters, I wanted to dig into that a bit more. Obviously, you mentioned the low serotonin aspect and the 5-HTP and that sort of thing. The neurotransmitters are also kind of a contentious topic because the testing, I know there's kind of debate over the accuracy of a lot of the testing methods for assessing neurotransmitter balance. Do you have any thoughts on the testing, and do you do neurotransmitter testing at all, or do you just kind of know that if somebody has fibro, they're pretty much guaranteed to have low serotonin?
Well, so as you said, the whole neurotransmitter, most people don't even bring this up, is contentious because, Candace Pert, who got the Nobel Prize for this, the research said she wished she'd never come up with the term. And we would not have antidepressants probably, or we wouldn't have selective serotonin, norepinephrine reuptake inhibitors. That's probably, we probably wouldn't have that. So there's a debate whether those medications or even the neurotransmitters, you can manipulate them. Having said that, I really believe that mono amino acid therapy plays and using that therapy is very, very important in my success. I don't do a lot of testing. I used to do a lot of testing with neuroscience and some of these other people where you could do urine-based or even blood-based, some of the blood-based testing to see about the neurotransmitters. And really for me, I got away from that partly because I didn't trust the testing and don't want to step on anybody's toes. But the other part of me is I could see the difference once I got somebody on 5-HTP or I got them on L-theanine or gamma-aminobutyric acid to calm them down or the methionine to boost their norepinephrine levels. I saw such positive changes that I just got away from the testing.
Excellent. Yeah, it's interesting. I mean, once if you as a practitioner know that a test is not necessarily fully valid, it almost becomes an ethical question as to whether you can then ask a patient to pay, let's say $300 or $500 to get this test that might not even give you accurate and meaningful data.
Yeah.
Right? So I like that you've kind of moved away from that testing. I think there's way too much of that going on where people are forcing hundreds and thousands of dollars on tests on people where the tests themselves have not even really been validated. Yeah.
Well, I do a lot of testing because of fibro. It's if you don't, you're doing a lot of guessing. But it doesn't make sense to do a test if you already know you're gonna go this other route. I mean,
right.
how does that change things,
Yeah.
So that didn't make sense at all. But I do blood work. I do functional medicine testing, test kits and whatnot, stool testing and these kind of things. Food allergies are very important. But with the neurotransmitters, and not everybody it doesn't work on everybody, but I would, 95% of patients that I work with respond to monoamine amino acid therapy because it's the amino acids that make these chemicals. It's not, no one has a Prozac deficiency.
Right.
You might have a 5-hydroxy or tryptophan deficiency. You may have a B6 deficiency, you may have a methylation issue, and by using these raw biochemical, these ingredients, you can make these chemicals. And that's really the way to go, because then you don't have all these potential side effects.
Yeah, absolutely. On monoamino acid therapy, for a long time in the fitness and sort of bodybuilding and fat loss space, there was a lot of talk of supplementation with branched chain amino acids and essential amino acids. This has been popular for, at least 25 years, maybe much more, maybe closer to 35. But more recently, just in the last few years, there was a number of studies that kind of came out showing that it didn't really matter whether you got your branched chain amino acids in the form of isolated BCAAs or in the form of, let's say, a whole protein powder from eating protein containing foods or protein powders and that sort of thing. Are you under the impression that taking the isolated amino acids is, in this other context that you're talking about, that taking isolated amino acids is very different from getting those amino acids in whole food form in the context of, also consuming it with many other amino acids?
So just to make sure I make the distinction. So when you say isolated, you mean mono, single?
Yeah. Like, so you're taking L-leucine by itself, or, proline or glycine or something like that by itself. Are they being metabolized differently when you take them by themselves on an empty stomach as opposed to in whole food form?
Yeah, they are. So you really, and I just explain it this way. If you take it singly, it almost acts as a drug. Now it's not a drug. It's, it's a chemical and it's natural. It's over the counter. But if you take it singly, then you can get a physiological reaction from that particular amino acid. A case in point, if you take SAMe, S-adenosine, or you take L-phenylalanine, these are two stimulating amino acids, you take those on an empty stomach, they can, and oftentimes do, cause you to feel more mentally alert. You have more energy. You can feel that pretty quickly. But now if you were to take L-phenylalanine in a powder with 21 other amino acids, you're really not going to see that. You're not going to see that physiological change happen, to you. So by using the single amino acids in a strategic way, you can see physiological changes pretty quickly. You're familiar with a lot of this, I know, but gamma-aminobutyric acid, GABA, or L-theanine, they're very, very calming, and you can take those on an empty stomach, and you can notice a difference within 20 minutes of taking them. Again, if you were to take them in a whole food product, you're not going to really tell any difference.
Mm-hmm. Interesting. So what's the next layer of the Murphree method? So we've covered sleep.
So we're looking at, the reason why you got to balance the neurotransmitters is because most everybody with fibromyalgia has some type of where they have low serotonin. We already established that. But so many of them have bankrupted these other ones that allow them not to feel so stressed out. And so many of those with fibro and even chronic fatigue syndrome, they feel anxious. They feel so stressed out. And if you think back, your listeners think back to a time where you felt stressed out all the time. Maybe that was during exams or, whatever it was. You may have to think way back, or maybe deadlines or work, or, whatever it is. You're exhausted, right? You mentioned earlier when you're under all that stress, it's just exhausting. And until you get that anxiety, that stressed out feeling to calm down, people are going to be they're going to be exhausted all the time. So by using the right amino acids, you start to fix that. Then number 3 is looking at, okay, because then by the time you start getting them going to sleep, they're going to have less pain, because when you go into deeper states of sleep, your pain threshold goes up. And a big part of that is because your serotonin level now starts to go up, and it blocks a hormone called substance P, so you have less pain. Now what you see is they want to start to get out and do more. The problem with that is they don't have the energy. They have a little bit of energy, but not a lot. So to help them with that part of it, you start looking at, do they have issues with, and we have already debated this, so let's don't go there. Do they have issues with their adrenal glands and low cortisol, low DHEA?
Well, I'll just jump in for a second. To be clear, I'm not saying that low cortisol states don't exist in some people.
Yeah.
I'm, as we said, I'm just saying it's hard to make a case based on the evidence that it's the primary cause of these conditions. But certainly they arise as a secondary factor and can then create other problems.
Yeah, so we can definitely agree on that, because I don't believe they're the primary cause for sure, without a doubt. So then you start working on those. So you look at, what can you do to help them to have more stamina, resiliency to stress. So my protocols, it is working on their adrenals, making sure that their levels are coming up, but also thyroid. That's a biggie. I see thyroid is a common thing that's missed in these folks, whether it's chronic fatigue syndrome or fibro. They're getting basic testing. They go and they're getting their TSH checked, and maybe their T4, and that's it. But there's all these other markers that would show you what's going on with thyroid that aren't tested for. So a lot of patients have all the symptoms of low thyroid. They, the low energy. You don't always have to have weight gain, but a lot of times you have weight gain, anxiety, low moods, brain fog, IBS, hair loss. Are you losing the lateral third of your eyebrows, dry skin, tingling in your hands and feet, nerve problems? And they get the testing done, and the doctor says, well, everything's normal. But obviously there's something going on there that, if you got all the symptoms of low thyroid, if you dig deeper, a lot of times you'll see that they have the beginnings of Hashimoto's thyroiditis, which is an autoimmune disease that starts to erroneously attack the thyroid tissue.
Yeah.
Not testing for that, you're not going to find it.
Right. There was a study actually that just came out, I think maybe 4 months ago, something like that, this year in 2018, that was looking at actually thyroid levels in people with chronic fatigue syndrome. And I think they specifically zeroed in on reverse thyroid hormone, and found that it was significantly higher. I want to say like maybe in the 30% of people with CFS that they had elevated reverse thyroid. So there's definitely an indication that a sizable chunk of people are, as you said, having thyroid issues for sure.
Yeah. So with reverse T3s you bring up, a lot of people will have a problem converting the inactive T4 into the active T3. And there's a hormone called reverse T3 that becomes elevated when you get under stress. We've been talking about stress. And if that reverse T3 gets to a point, it can block the conversion of T4 into T3. And that's a very common problem with patients who are on synthetic T4 medication like Synthroid or levothyroxine. They're on those medications. They go back every 6 months and their doctor says, oh yeah, your blood work looks fine. And they can barely get out of bed. They're losing their hair. They have PMS. They have anxiety. All the things that we see, the symptoms of low thyroid, that's not getting better. And that's because that medication is not converting.
Very interesting. So what do you do in those cases when you're finding those thyroid abnormalities, and if they're kind of on the subtle side where, let's say, it's not an overt deficiency in T4 or T3, and it's, there's kind of very subtle things going on, are you still using exogenous thyroid hormones, or how do you navigate that situation?
Mm-hmm. So if we look at, if it's Hashimoto's, what we'll see is they'll have elevated antibodies, TGB and TPO antibodies. And those antibodies become elevated when the thyroid gland is being attacked. And that can be from all sorts of things. It can be from low vitamin D, it can be anemia, people who have chronic anemia, can be gluten intolerance, it can be from Epstein-Barr virus, cytomegalovirus, where the body, unfortunately, is associating the thyroid tissue as a foreign invader. And you can have these elevated thyroid antibodies for 5-10 years, and still your TSH, your thyroid stimulating hormone, look normal. And so the doctor erroneously thinks you're okay. And then one day, though, your TSH spikes up. And when it does, now they say, oh, you have hypothyroidism. Let's put you on Synthroid levothyroxine. The key in that model is to treat what is the trigger that's causing the Hashimoto's. Is that gluten? Are you gluten intolerant? Do you have low vitamin D? Do you have a virus? Classic chronic fatigue syndrome, Epstein-Barr virus, cytomegalovirus, mycoplasma. What do we need to deal with to stop the body from attacking the thyroid? The other part of that was if I have someone that has an elevated TSH or has, the thing about the TSH model is, and I'm sure you know this, is that years ago they changed the parameter so that your TSH, it used to be if your TSH was above, it used to be if it was above 10, then they would put you on thyroid hormone. Then it slowly has gone down. Now it's depending on where you're at in the country or the world. So I work with patients all over, but now it's 5.2. So if your TSH is above 5.2, they put you on thyroid hormone. But what we know, functional medicine doctors and endocrinologists who specialize in this, they'll say that anybody with a TSH above 3 needs to be on thyroid hormones. So just want to get that out there. Mm-hmm. When I see that, here's the answer to your question. But when I see that, Ari, I put them on over-the-counter thyroid. So it's T3. It has no T4 in it. It's a glandular. That makes it legal to be over-the-counter. And they start using that. And then when we retest, we start to see the TSH come down, the T3 go up, or the reverse T3 start to come down, whatever it is we're after.
Gotcha. So the next layer of the Murphree Method is gut health.
So gut, and the thing about your gut, it's all connected, right? I mean, it's connected, and you have more serotonin receptors in your intestinal tract than you do in your brain, and people don't realize that. But when you get nervous, you get butterflies in your stomach, and so what happens is as you deplete your serotonin levels, you deplete them in your stomach as well, and now you have serotonin helps to regulate the motility of your food. When you get really low in serotonin, one of the things that happens is you're predisposed to IBS. And so you got to correct that, because the other thing that happens is T3 conversion is happening in your gut. You got to have good gut bacteria to help you digest certain, to make certain hormones and to make certain vitamins or minerals. But you also have to have it to keep you from not having yeast overgrowth and SIBO and all these other things. And if you're having a trouble breaking down your food and then absorbing the nutrients, you're always going to be at risk to being, having the symptoms, the warning signs that we see in fibromyalgia, whether that's pain, low energy, or brain fog. Gotcha.
So what specific gut issues do you think are most common or most associated with chronic fatigue syndrome and fibro?
So most have an issue with malabsorption or reflux or GERD, gastroesophageal reflux disease. So many of them have that common denominator where they just don't absorb their food, and so many folks are on proton pump inhibitors or acid blocking medications. And what they don't realize is that's sabotaging you long-term, because the stomach acid plays many important roles. One of which is it helps to prevent foreign invaders from getting into the rest of your body. So the stomach acid is supposed to kill bacteria and yeast and these microbes, these pathogens that come into our body when we eat. When you eliminate that stomach acid, you start to have problems with absorbing and manufacturing B12. You can get deficient in thiamine, and then you start getting deficient in those things, and then before you know it, you get labeled with pre-senile dementia or Alzheimer's or worse, right? And some of that's coming from the fact you're just not producing enough B12 because you're blocking the stomach acid. It won't allow you to do that. So to answer your question, a lot of my patients, the majority of my patients, go on digestive enzymes to help them make sure they're breaking down their food. We're told you are what you eat, and people become pretty jaded to that, but it is true. I mean, it's so very true. But just as important, you are what you eat, but you are what you absorb. And so many of the individuals with chronic illness, they're just not even absorbing their food, so they're not getting the nutrients.
Mm-hmm. Are there any other gut issues? Do you do any things with like, for example, gut permeability or dysbiosis? Do you kind of examine those and go about treating those as well?
Yeah, absolutely. So the and this is where the testing comes in. So otherwise, you're just guessing. And what I found, there's no one. You can't just put everybody on this one protocol. However, you can follow a process that if you put it in the right order, you set people up to have the most success. So my success with fibro is about 85%, which is pretty dadgum good for that group.
Yeah, that's great.
And that's why I'm so adamant about a process, because I think if you don't do a process, you could go down the rabbit hole of so many different things and never come out. And because there's so many problems, where do you start, right? But to answer your question, I test. So I want to look, do they have leaky gut? And if they do, then I correct leaky gut. Do they have small intestinal bacterial overgrowth? If they do, we start to correct that. Do they have food allergies that are playing a role in their migraine headaches or in their pain or in their IBS? Do they have yeast overgrowth? Do they have parasites? I'm not one of these people that thinks that everybody's who has a chronic illness, has chronic fatigue syndrome. It's because they have a parasite. I believe it's an assortment of all these things that come together that then put the person in the state that they're in, which is poor health.
Right.
But by testing, I can sift through who needs what, who does have who has a problem where, and then start addressing those things.
Mm-hmm. What do you have any recommendations on specific tests that you think are better or worse for those things? Like I know food intolerance is obviously a very contentious issue. A lot of people say that IgG food intolerance testing is just not valid. But do you have any thoughts on like gut permeability tests or the stool testing to take a look to test for parasites or things of that nature?
Yeah. So there's a lot of great labs out there, and don't want to burn any bridges, but I like, and I use a lot of different ones, but for yeast overgrowth and for stool testing in particular, like Genova, Great Smokies, they started as a stool testing company. That's really how they started back in the 80s, back in the 80s. And I really believe that's, they've done it for so long. So stool testing for Candida is one approach. I also like to look at Candida antibodies, which is a blood test. Looking at leaky gut, Genova has a test. There's Diagnostic has a test. So there's different people have tests for that. Food allergy, there is, and I'd be the first one to tell you that the ELISA test or even the ALCAT test, to controversial tests, especially in the conventional medical world, because no allergist in the conventional medical, very few I should say, they do the skin prick test or the RAS test, and they don't really believe in the delayed sensitivity IgG test. I do, with the caveat that you're going to get false positives and you're going to get false negatives. It's just the way it is. But it's a tool. That's it. And it depends on how you use the tool. It allows the patient to at least be able to have something that they can see, that they can steer clear from. And then I combine that with them doing an elimination diet too, and a challenge diet on the back end of that. I do all those. I do all those testing. Yeah.
Nice. Is there any other layer to the Murphree method beyond the gut? And I don't want to keep you over time too, because we've gone about 5 minutes over. I don't want to assume that you have time. Do you have a hard cutoff coming up?
No, I'm good.
Okay.
So now it gets interesting, because as you said, there's layers. So you can take somebody this far, and then most of the time, and I tell you, all right, if you can get them in a deeper state of sleep, you will see big improvements in these folks. Now, one of the challenges that I find is that when my patients are on half a dozen to a dozen drugs, and those drugs are causing problems, they're contributing to their symptoms. if you look at sleep medications like Ambien, the potential side effects of Ambien are diffuse achy muscle pain, brain fog, irritable bowel, restless leg syndrome, anxiety, depression, poor coordination, balance issues. What does that sound like?
Yeah, it sounds like the symptoms of CFS.
Fibromyalgia or CFS, right? So, and so you got, so I have to only when they're doing better, slowly wean them off these medications as they're getting better. And then what they see, whether it's Lyrica or Ambien or Savella, Cymbalta, or opioids, whatever it is, as they are able to get off of these, oftentimes they see that their aches and pains, and obviously their energy and things, their moods, these things actually improve coming off these medications.
Mm-hmm.
So that's one layer, and that's that can be a pretty tough layer with some of these folks. But then it could be if they're not making progress, maybe they have a problem with heavy metal toxicity. Mm-hmm. And I'm not one of these doctors that thinks that everybody needs to have their amalgams taken out and be chelated. Although when I had my medical practice, we had a huge chelation practice. But there's definitely layers, and some people can get so far, and then you're going to have to look, deeper. Some of these folks, have Lyme disease that have never been properly diagnosed. So it's different paths for different people, and the patient results is going to dictate where you go next.
Mm-hmm. Interesting. So at that point, after sleep, neurotransmitters, hormones, gut health, at that point you kind of have an array of just different testing options to figure out what's going on in that specific individual.
Yeah.
Okay.
Yeah. And in part, so case in point, if they're carrying around 40 extra pounds, and a lot of my patients that I work with are overweight. I mean, our population's overweight. But in the fibromyalgia CFS community, because they've gotten so run down, they can't exercise, and so many of them have a sluggish metabolism. It doesn't matter what they eat or don't eat. They gain this weight over a period of years. And you combine that with medications that can cause them to gain weight, like some antidepressants and Lyrica and Grillis and Neurontin, these things that are notorious for causing weight gain. They've got to lose that weight. And the reason that is because that's where they're storing inflammatory chemicals. Any extra fat cells that you have, you're storing toxins and you're storing inflammatory chemicals. And until you start to get rid of those chemicals, get rid of that weight, you're going to see that you're going to struggle. And part of that is, this is so obvious that, and when people hear it, they realize this, but sometimes they don't think about it. If you're carrying around 40 extra pounds, that's a lot of daggum weight. That'd be like me carrying around, a 5-year-old kid on my back all day. That's exhausting. It's exhausting to your circulatory system, your respiratory system, your joints, your everything. So by losing the weight, what they see is typically their energy goes way up and their pain goes way down. So sometimes that's the last thing that has to happen for them.
Mm-hmm. Do you mentioned heavy metals. Do you put a lot of focus on toxins and detoxification? It's I have to say it's interesting having this conversation with you, because a lot of the CFS experts that I've had on this podcast either fall into the category of really hyper focusing on what's going on in the brain and addressing the stress component, and oftentimes they have sort of their methods for addressing that component, and even some people that's their whole approach, is just to address the brain through affirmations and different cognitive behavioral techniques and meditation and yoga and that sort of thing. Mm-hmm. And then I also know some CFS doctors who are hyper focused on infections and toxins, and that's kind of like all their attention goes there. I actually have to say that I really like that you're kind of doing this in a more holistic and all-encompassing sort of systems biology perspective, where you're systematically addressing all these different layers and giving them all a lot of attention rather than hyper focusing on just one or two. But what degree of importance do you think toxins and infections play in chronic fatigue? Do you think that they are, right up there as some of the most important things to address? And they're just, I know some doctors who feel that infections are pretty much going on in everybody with CFS, and that's where almost all their attention goes. Are you on board with that, or do you differ from that considerably?
Well, I think it's important not to have. I think it's important not to be a carpenter, and that everything looks like a nail or a hammer. What's that saying? You're a carpenter and you have a hammer.
If
So I
your
think
only tool is a hammer, everything looks like a nail.
perfect.
Yeah.
So I think you got to be careful, because if you do that, you pigeonhole yourself into that mentality, and you're going to miss a lot of things.
Yeah.
I will say, Ari, that for ME, chronic fatigue syndrome, I think viruses are huge. For fibro, not so much. And so when we got vaccines they're trying to do for fibro, and people are saying it's all due to a virus. I test them. I don't see it. I mean, I tested for years and years, and sometimes I still will. I don't see them. I mean, I would do these big old panels. Chronic fatigue syndrome? Oh yeah, definitely. But I think it's and that's what really separates the two, fibro and chronic fatigue syndrome, ME, is, in my opinion, there's definitely some type of there's an immune component here that's not in the fibro community, and this immune component is typically some type of virus, mycoplasma, something that is really wreaking havoc. Could be Lyme disease even. And toxicity issues are much more important in this group, the CFS group, than they are in the fibro. Much more. And if you look at research, you'll see that those with CFS often have parts of their brain. They have a lot of white matter where they have toxicity issues that even show up in PET scans. You see that many of them have chemical sensitivity, so they have something wrong with their liver. They can't process chemicals like a normal person would, much more than the general population, and much more than you would in fibro.
Interesting. I have one more question for you, which is POTS, postural orthostatic tachycardia syndrome. I know there's a number of different kind of theories, and I don't know if the research is really clear yet on what actually causes this, but do you have a sort of preference? How do you explain that syndrome, and what kinds of strategies do you use to try to fix it?
So I see.
And you know what? Sorry to interrupt, but we should also maybe explain what that is for people that are unfamiliar with the term. Do you want to take that? Okay.
Yeah. So with POTS, when you have POTS, the thing about it that really is, I think, a challenge for me is that they lump POTS in with like dysautonomia, and early on, everybody that had fibro, everyone had dysautonomia, dysfunction of the autonomic nervous system, and that's just not the case. So with POTS, positional obstructive tachycardia, is that right?
Or orthostatic.
Orthostatic. Sorry, I knew my mind went blank. Right.
Syndrome.
So what happens is when you go from lying down or even sitting, and you go to stand up, you get this misfiring in your body's system, and the heart goes crazy. And I see a portion of that in a lot of my patients, but not as pronounced as, say, someone that would go get the tilt table test and get the diagnosis. And so I'm definitely not an expert, and I'm really a little bit biased, because I think that dysautonomia is a term that leaves a bad taste in my mouth for a lot of reasons. Having said that, in full disclosure, I had a patient a few years ago who was a young patient. She was, I think she was 11 years old. And I was doing the Murphree Method, doing all these things. And then I realized her parents kept sharing this stuff to me. And I realized just intuitively I needed to get her to a POTS specialist. And sure enough, that's what she had, even though I didn't want to believe that, but I just intuitively knew I needed to get her to this person. And sure enough, once he started treating her, everything I had done, which was a big improvement, but everything just fell into place for her. And she's totally normal now. So I had to eat some crow.
Very interesting. I actually lied. I have one more question for you, which is what we haven't talked about, like meditation or yoga or any sort of, I guess you could say, like de-stressing techniques that are targeting the brain and sort of calming the brain and vagal nerve activation and that sort of thing. do you use meditation or yoga or any particular sort of de-stressing technique in your practice? And do you find it to be very helpful?
I do. I mean, so I'm really 87, and it's worked for it's worked for me. I mean, I meditate every day, I exercise every day. I just don't know how you could, being in a high stress environment that we're all in, I don't know how you could survive it if you didn't have some techniques to do it.
Yeah.
So one of the chapters in my book is all about that. It's all about, you can't separate the mind from the body. It's all connected. And it's, the thing is, everybody's under stress. I mean, you're under tremendous amount of stress. I know you're a super busy guy. We're all under so much stress. And the key is, it's not, you can't go, well, maybe you can, I don't know. Maybe you can go live in a cave and be in India and be a shaman or whatever it is, but most of us can't do that. We have families, we have people, that depend on us. So the key is to protect yourself from the stress, because the stress is not going to get any less. Mm-hmm. It's only going to get more. I mean, as we're doing this interview, I've got my phone's blowing up with, I think I just glanced at it a minute ago, and I got 15 texts.
Oh, geez.
And, you got to answer them,
Yeah.
We're conditioned that way. But what I really ask of my patients is, in the beginning, they don't even feel like they can't even think, they're so, when you and I can, we can have positive thoughts. We can have rational thoughts. We have habits, really healthy habits. We eat well, we exercise, we do these things, and we do them. But even for us, I know for me, when I do get sick, I don't get sick very often, but when I get the flu, that goes out the window. I mean, I'm gonna, forget positive thinking, forget meditation, forget exercise, forget eating healthy. I'm going to eat whatever, and that's where they're at in the beginning. But as they get feeling better, then absolutely, I want them to spend, I call it, for me, it's the hour of power every day. So every day for an hour, it's meditation, prayer, reading something positive. I don't start the day reading the news. I mean, that's a disaster. I haven't watched the news in 15, 20 years. But it's that hour of power. And for it may not be an hour for you. Maybe it could be a quarter of an hour of power, to where every day you're in that habit. The first thing I do before I get out of bed, and this is from one of my mentors, the 4-Hour Work Week, Tim Ferriss. So, he talks to one of the people they interviewed, and I can't remember the book now. My brain's drawing a blank. Titans something, but
Tools of Titans.
Yeah, thank you. So one of the things is being grateful every day before you get out of bed. I think we don't do that. And so every day before I get out of bed, before I even get out of bed, I was thanking God how grateful I am for, different things in my life. It changes. I want to look back on the day before, and I will say, thank you, and that's how it starts. And I think if we can instill that in our patients, to be grateful, because there's always going to be somebody that's worse off than you. Always. And if you can have that mindset, even on your worst day, there's a ray of hope that you're going to have some optimism that the next day is going to be better.
Mm-hmm. Yeah, absolutely. So I really enjoyed this conversation, Dr. Murphy. It's been an absolute pleasure. And thank you for hanging out with me a little overtime. I appreciate that as well. Where can people find more about your work? And I guess that's the first question. And then the second question is, if somebody wants to work with you one-on-one, if they've got fibromyalgia and chronic fatigue syndrome, where can they find you? And what is your ideal client? Like who should kind of, if you want to speak to those people directly and say, if you're experiencing this, this, and this, I'm probably a good fit for you to work with.
Well, first of all, I want to thank you for having me on here, Ari, because you have, I've watched your podcasts, and I've listened to them, and I've seen some of your guests, and I feel really honored to be on here. You're doing amazing work, so I really appreciate you reaching out to me. I really appreciate this opportunity to share my message. I'm definitely on a mission, because with fibromyalgia right now, if you go to Mayo, they'll do this incredibly $1,000 workup, and at the end of it, they'll say, yeah, you do have fibromyalgia. and they're going to stick you in a 2-week class to learn to live with it with the sociologist and a psychologist.
Right.
And that's it. I mean, that's it. So I'm on a mission to educate people. Don't learn to live with it. I mean, who wants to live with chronic pain and no energy and anxiety and depression and irritable bowel, can't sleep? That's not living, that's existing. I'm on a mission to help people learn how to overcome it. And as far as reaching out to me, the best way to do so, just go to my website, doctorspelledout.com, yourfibrodoctor.com. There's a tremendous amount of free resources on there. They can take advantage of videos, blogs, all of it free. And if it resonates with you, then reach out, and would love to be helpful in any way that lines up with your goals.
Wonderful. Well, Dr. Murphree, it's been an absolute pleasure having you on. I've really enjoyed this, and I look forward to a part 2 sometime. It'd be great to have you on again.
Absolutely. Sounds great. Thanks, Ari.
Great. Take care. Hey there, this is Ari again. One more quick thing before you go. Just make sure to subscribe to our YouTube channel, The Energy Blueprint, and also make sure to subscribe to this podcast on your favorite podcast platform, whether that's iTunes or Stitcher or anything else. I hope you guys enjoyed this interview, and I will see you again next week.